Med Practice Education. Surfactant with ARDS. Hello, my name is Avdeev Sergey Nikolaevich. I am the head of the Department of Pulmonology at the First Moscow Medical University. And the topic of the message that I want to share with you today is devoted to a new, and at the same time very well known, trend in the treatment of severe respiratory failure. Surfactant therapy for treating ARDS. A word on surfactant. Surfactant is a complex substance composed of 85% phospholipids, 5% neutral lipids, and 10% proteins A, B, C, D. Surfactant is located on the border of air and liquid, and covers the alveoli and small airways from the inside. Surfactant is of a great importance. First of all, surfactant has the ability to reduce surface tension at the alveoli level. Thus, it prevents the collapse of the alveoli. There's a complex law of Laplace, according to which the smaller the diameter of the bubble, the greater the pressure inside. So, the role of the surfactant is such that this pressure should be as low as possible. Indeed, our alveoli do not collapse thanks to the surfactant. And the second, very important surfactant feature is that it not only prevents the collapse of the alveoli, but also the collapse of the airways. Pay attention to this figure. The size of the airways is different during inhalation and exhalation. If there was no surfactant, then such a fate would await us, that the liquid phase would completely block the respiratory tract. When there is a phospholipid protein complex in our small airways, this doesn't happen. Talking of ARDS, I hope everyone knows what I'm talking about. I'm talking about pulmonary edema, non-cardiogenic pulmonary edema. But perhaps the key point in terms of pathophysiology is that this non-cardiogenic pulmonary edema has an inflammatory cause. Pay attention to alveoli differences. Normal one is on the left. The right alveoli half is injured. We see inflammatory elements. We see an increase in the permeability of the alveolar capillary membrane. In such conditions we can obviously suppose that all structures connected with alveoli are changing, including surfactant properties. This is true. At least, today we can quote lots of research works that show the fact that in case of ARDS, surfactant really changes its properties. The first research was made quite a long time ago. Pay attention to the date, 1982. However, this research is still up to date. In ARDS, the proportion or percentage of phosphatidylglycerol from the total level of phospholipids is significantly reduced in comparison with normal people. This decline is at least described as several times. In addition, there is a change not only of phospholipid properties, but also of proteins that are part of the surfactant. One more research. Note that the surfactant level of specific protein A is being studied in lavage. Patients with ARDS have it is significantly lower than the healthy volunteers. That is, we are talking about the fact that the properties of the surfactant are changed. And one more figure that describes surfactant properties. Difference of control between healthy people and patients with ARDS. I draw your attention to those properties that describe the size of the aggregates. With ARDS, in pathology, most of these aggregates, they are completely different. These are small aggregates. While normally, the opposite is true, the aggregates are usually large. So, surfactant properties change. The proportion of surfactant changes, as well as its amount in the respiratory tract, in terms of how much the replacement of a defective endogenous surfactant by an exogenous surfactant matters in case of ARDS. Today, I think, this question is still actual. We can say that the first studies appeared more than 30 years ago. One of the first and most successful studies is demonstrated here. The surfactant was administered by inhalation. The drug that was then chosen as such therapy was called Exosurf. Please note that prescribing surfactant in two different amounts We managed to reduce mortality for patients with ARDS. One more research. The study, again, was conducted in the late 2000s, but is actually significant. Endobronchial administration of a surfactant leads to improved oxygenation, a clear dependence on the moment of administration, and improvement of the oxygenation index in case patients have ARDS. Despite these impressive but small studies, it was decided to conduct a large randomized study. One of the largest was conducted and published in 1996. The first author is Antonio Anzueto. The study was randomized, carried out according to all the canons of evidence-based medicine. Exosurf, which was administered by inhalation, or placebo, which was administered by inhalation to patients with ARDS. We see no complications in both lines. Not in the diagram that shows the alveolar arterial gradient, nor in the diagrams that show the oxygenation index. Everything is exactly the same there and there, and all other parameters were absolutely similar. That is, this is a negative study. No surfactant effect has been shown. And, indeed, if today we analyze the works that are devoted to the effectiveness of a surfactant in ARDS, this is a great review article by Professor Rosenberg, who for many years dealt with the problems of surfactant in acute respiratory failure. I would like to draw your attention to the column called mortality. Somewhere there is no effect, somewhere there is. That is, in fact, we see absolutely multidirectional data. What is the reason for this? According to Rosenberg, there are lots of reasons. It's true. I draw your attention to the fact that there's a different structure of drugs. Different doses, different times, different delivery methods. If we're talking about the drug structure, probably I can cite publications of the same author as an example. Please note that today all surfactant preparations that exist on our market, or have existed, can be divided into synthetic, natural, natural modified and non-modified. There are human forms of surfactant. If we talk about the effectiveness of these forms, definitely a human surfactant takes the first place in terms of effectiveness. But it is a therapy that today is essentially limited to pediatric cases. And more promising is the use of natural preparations of surfactants, especially non-modified ones. And among them we see the drug surfactant BL. I would like to especially note that this is the Russian formulation. And it's the only surfactant in the world that is for now registered as administrative in case of ARDS. As an example of why this became possible, we can quote our Russian studies, which show that using this particular surfactant in a number of studies has led to an improvement in the condition of patients. In particular, we can say that there are responders and non-responders to the drug administration. Of course, the mortality results are completely different. Responders have better results. If we look at other effects of surfactant therapy in responder and non-responder groups, responders have better oxygenation index. The least scale lesion index is lower, and period of administration is also less. That is, it reflects a more benign and more favorable course of the ARDS disease against the background of the administration of a surfactant. Methods of surfactant administration. Today, the main methods are: the first is aerosol, or nebulizer method of delivery. The second is bronchoscopic. During bronchoscopy, the drug is instilled. And the third is endobronchial, but without a bronchoscope. That is, the so-called endotracheal instillation. This is another method of surfactant drug administration. What can we say today about the success of this or that method? Most experts agree that the most successful methods are direct delivery. That is, endobronchial instillation or bronchoscopic administrations. But, nevertheless, let's turn to our domestic preparations. Surfactant BL has several methods of delivery. Here is a figure of how it is delivered to the respiratory tract. Endobronchially. If endobronchial administration is impossible, during artificial lung ventilation, through a nebulizer connected to the circuit, endobronchial bolus, and the last one. If patients are not intubated, the drug can be delivered using nebulizer therapy. Usually, about 75 to 150 milligrams is administered per one administration, one inhalation, twice a day, as a rule. If we talk about the modern experience of surfactant preparations, let's go back to our recent history. A pandemic of a viral infection, but not COVID-19, but influenza H1N1. That is, about 10 years ago. During this new infection associated with severe pneumonia and ARDS, the effectiveness of the surfactant drug has been shown both in domestic studies, like this, as well as in a number of foreign studies. And today we're coming back to the question, which is possibly of a great importance to us. Possibility of surfactant administration in case of non-critical patients. That is, in the earlier stages of ARDS development. I'm talking of patients that are not intubated. That is, they breathe spontaneously. And please, note, from the point of view of nebulizer therapy, today we see that there are different classes, and, in fact, probably the most interesting, from the point of view of efficiency, is the class of mesh or membrane nebulizers. A number of them are presented in the picture. One of the nebulizers, like this one in the figure, can be used for patients with spontaneous breathing, and during non-invasive ventilation. That is, it is quite possible to integrate this nebulizer into the circuit of non-invasive ventilation. Last but not least, I present the first results of a pilot study. Of course, this is far from all the work. But, nevertheless, I think that these results will seem interesting to many.
Patients with COVID-19 associated pneumonia,
Not intubated, but having respiratory failure. As criteria for severity, pay attention to oxygenation index 166 to 139.
these are patients with moderately severe ARDS.
Patients with severe inflammation. According to the CT picture, it is CT3 or CT4. According to the well-known classification. Well, I draw your attention to the fact that the appointment
Of an inhaled surfactant to patients with COVID-19 associated pneumonia
led to a faster decrease in the number of points on the news scale. In other parameters, it would seem, there are no changes. But if you look at the surfactant group and the control group, we see large differences in transfers to the intensive care unit, tracheal intubation and mortality of patients. Of course, I'd like to emphasize again, this study is not randomized. This is a case control study. Of course, there are big weaknesses in the design of the study. But thanks to these pilot results, a large randomized study has been initiated in the Russian Federation today, which is dedicated to this problem. The efficacy of the inhaled drug surfactant BL for patients with ARDS associated with COVID-19 associated pneumonia. I think we'll know the results in the nearest future. Thank you.
Результаты, я думаю, мы узнаем в ближайшем будущем. Спасибо.